Hello everyone and good evening. I'm Dr. Shayma Deshti, a general surgeon in Amiri Hospital. I'll be hosting today's session, Peritoneal Surface Malignancies, Overview Approach to Management and Local Experience, which will be given by Dr. Ali Safar. Dr. Ali Safar is a board-certified general and colorectal surgeon with a dedicated training in cytoreductive surgery and HIPIC. He is here with us today to give us an overview about the procedure and share their local experience. Before starting, please, if you have any questions, type it down in the Q&A panel, and we will come to it at the end of the session. If you have any point to discuss verbally, please wait till the end of the session, where we will have 10 to 15 minutes for discussion. Now, I think we can start. Dr. Ali, we're ready for the session. The mic is yours.
Thank you, Dr. Shayma. Good evening, everyone. Thank you for joining us this evening. Tonight we'll be talking about a subject that's not very common. Actually, it's considered one of the rarest diseases in surgical practice. We'll be talking about peritoneal surface malignancies. We'll be discussing the overview, approach, and management, and our local experience. It's quite a small experience with a few cases, but we're hoping to expand on that soon. So to start with, Mr. John Boney from England said quite an interesting thing that we need to think about, and when we'll be discussing further as we go through the presentation. Peritoneal metastasis treated with a good surgery in the right patients is not a terminal process anymore. Up until very recently, peritoneal metastasis or peritoneal carcinomatosis is frequently considered a terminal event in cancer progression, where patients were frequently referred to palliative care, and often they died a terrible death accompanied by some major suffering. I have no disclosures. So our content of our presentation today will be going over the terminology. We'll be discussing primary and secondary peritoneal surface malignancies, going through the pathophysiology, approach, workup, and management. And we'll be talking about the rationale for the HIPIC component of the cytoreductive surgery and HIPIC, going through tailoring of care, and finally our local experience in Amiri Hospital, Kuwait. So there are some terminologies that are unique to cytoreductive surgery and HIPIC or peritoneal malignancies. Redistribution phenomenon. I have a couple of slides where we're going to go through that. Lamin, Hamin, mucinous adenocarcinoma, DPAM, and PMCA. Basically, Lamin is a low-grade appendiceal mucinous neoplasm. Hamin is a high-grade appendiceal mucinous neoplasm. They're different than adenocarcinoma in the sense that Lamin and Hamin share different degrees of cytological atypia, but both have no invasive growth beyond the basement membrane. So they are characterized as malignant etiologies, but they differ from adenocarcinoma in the sense that they do not invade the basement membrane. Mucinous adenocarcinoma is an adenocarcinoma with a mucinous component. They're often categorized as moderate to well to poor differentiation with infiltrative invasion through the basement membrane. PMP, pseudomyxoma peritonei, again, I'll be going through that in further depth in the coming slides. Mucinous adenocarcinoma with signet cells versus signet cell adenocarcinoma. Basically, I'm sure most of you know that the presence of signet cells in almost all adenocarcinomas confers a worse prognosis. But what the difference is between mucinous adenocarcinoma with signet cells and signet cell ring adenocarcinoma is mucinous adenocarcinoma with signet cells. Usually the component of signet cells is 50% or less. Signet ring cell adenocarcinoma is a component of signet cells that's more than 50%, obviously conferring even worse prognosis. Colorectal peritoneal metastasis, will be saying CPM, will be abbreviating a lot of those. I'm sure you can tell that they're all a mouthful. So we'll be using some abbreviations. So CPM stands for colorectal peritoneal metastasis. Cytoreduction is the procedure of removing all visible peritoneal nodules, and we'll be going through the procedure and how it differs from debulking, maximal tumor debulking. HIPEC is the portion of the procedure where heated chemotherapy is instilled into the peritoneum. Again, maximal tumor debulking is one of the approaches that are used, and we'll be talking about the effectiveness of that approach. And tumor cell entrapment hypothesis. This is a very important hypothesis, although I don't know if we still consider it a hypothesis. I think it's something that we consider a reality by now. I'll be talking about that as well. So peritoneal surface malignancies are rare and uniformly fatal. They're regarded as either mixed versus disseminated regional disease. Now this, we really need to go in depth if we're going to analyze and individualize treatment for each and every patient. Should we consider a peritoneal metastasis or peritoneal cancer as a systemic metastasis, or should we consider it as a dissemination of a regional disease? This will make a huge difference in our approach to treatment, and we'll be discussing this further as well. Again, peritoneal metastasis is considered a treatable condition depending on several factors: tumor histology and biology, burden of disease. We'll be going through that, patient factors, and the local expertise of the center. This is just a quick diagram showing us the peritoneal cavity. This is basically a normal picture of the peritoneal cavity, showing us the potential spaces. That's the omentum. Here, more or less, that's the Douglas without the uterus. And this other picture shows us the circulation of peritoneal fluid in normal individuals. So we've got a pre-existing peritoneal compartments where peritoneal fluid can circulate. Usually, the circulation is based on breathing patterns, which cause alteration in abdominal pressure, as well as the intestinal peristalsis. So usually the fluid ascends through the right paracolic gutter, ascends through on top of the liver, and then goes down, limited by the falciform ligament, and into the inframesocolic plane, and then gets back to the pelvis where it's recirculated right and left. And these small stars show us where potential spaces for cancer cells where they may implant and reside. So we can almost say for certain that there's a predictable pattern of dissemination of peritoneal cancer. And the pelvic dissemination usually occurs due to gravity. And there is relative sparing depending on the tumor biology and tumor histology. There's usually relative sparing of mobile organs, which includes the small bowels. So this is just a schematic of how cancer cells attach to the peritoneum, and it just shows that free-floating cancer cells usually adhere to the peritoneum and then invade through the submesothelial extracellular membrane. So now this does not happen with all peritoneal carcinomatosis or with all peritoneal mets. Again, it depends on the histology of the cancer nodule, and we'll be talking about this again and further. Again, that's a quick diagram of how free intraperitoneal cells implant. So you've got free-floating intraperitoneal cells circulating through the abdomen at predetermined sites that we know of, and then they implant into the peritoneum. Some of them gain hematogenous spread, some of them just seep into transmesothelial spread and translymphatic, and then we get a variety of ways of distribution. Now, this is a very important slide. This is the tumor cell entrapment hypothesis. This is, as is for gastric cancer, but we can apply it to almost any cancer. When we're primarily resecting cancer, our aim is to go for an oncologic resection. This is as a general concept, not with cytoreductive surgery and HIPEC. Our aim is to go for an oncologic resection. We have the concepts of minimal handling of the tumor, no touching, and trying to resect as many malignant looking nodules or lymph nodes as possible. Now, what happens if we resect a tumor and we do not achieve complete resection? Basically, this is what happens. You cut through the tumor, and then you get lymphatic dissection, you get intraoperative hemorrhage because the planes are not clear. And then what happens? The tumor cells basically become free as emboli in the peritoneum. As the patient recovers from the surgery, they heal, and then obviously healing in the abdomen happens by fibrosis. The cells get entrapped within those loculi of fibrin, and then you get inflammatory cell infiltration because of the healing process, which is often accompanied by growth factors, which usually aid in the healing process, but also cause more growth factors for the cancer cells. So basically, surgical trauma without complete cytoreduction, as we say, is basically a disadvantage for the patient and the surgeon who's going to operate next, because we usually were not able to see those hiding cells that are beneath the fibrin deposits. And usually you get cells that are not in the predetermined intraperitoneal locations. They're hiding retroperitoneally. They've gone somewhere else, and then makes it difficult for the surgeon to achieve a complete cytoreduction. Usually what we say is the first surgery is usually the most successful one. As we operate more and more on patients with recurrences, whether intraperitoneal or local, the surgeries become more difficult, the chances of complications become more, and the chances of success of achieving complete cytoreduction become much less and less, and this leads to a much worse prognosis for the patient. Okay, so when we're talking about peritoneal carcinomatosis, we need to stratify them. We usually stratify them by the disease burden or the disease load. In this, the peritoneal cavity is divided into 9 segments, and the bowels, the small bowels, are divided into 4. So basically, when the surgeon goes in either to diagnose with laparoscopy or going in for the primary, for the cytoreduction, usually we have to quantify the extent of the disease. Extent of the disease is given a PCI, peritoneal carcinomatosis score, based on the 9 quadrants and the 4 bowel regions and the lesion size. So we get a maximum score of 39. And then after the surgery is completed, the complete cytoreduction or whatever, and the HIPEC, then we assess the completion of cytoreduction score. Usually, based on the best available research, it's ideal to achieve obviously a completeness of cytoreduction score of 0 or at least 1, where the nodule is less than 0.25 of a centimeter. All of this is for the purposes of penetration of the chemotherapeutic after the cytoreduction. All right, so peritoneal surface malignancies usually include a variety of tumors. We've got primary peritoneal surface malignancies, which include mesothelioma, and we've got secondary, which include basically pseudomyxoma, colorectal, ovarian, appendiceal, and many more. Primary peritoneal surface malignancies include peritoneal mesothelioma, primary peritoneal carcinoma, and cystic lymphangioma. And peritoneal mesothelioma, being the more common of the very rare disease, is further stratified into low-grade, multicystic, well-differentiated, or diffuse malignant, which is also stratified into epithelioid, sarcomatoid, and biphasic. As a general rule, peritoneal mesothelioma is generally confined to the peritoneum and has low potential for distant metastasis. Secondary peritoneal surface malignancies include pseudomyxoma, we'll be talking about that in a minute, and appendiceal adenocarcinomas, ovarian, colorectal, gastric, biliary, urachal, and many more. All right, so pseudomyxoma peritoneal, it's a very broad term, and it was previously referred to as jelly belly, basically because of the presence of extensive mucin in the abdominal cavity. It was first described for ovarian tumors. It's usually secondary to mucinous neoplasia. It has an incidence of about 22 million per year. usually results from a perforated mucinous tumor versus exfoliation. This is another concept we need to discuss. Intraoperatively, tumor perforation is not always seen. Again, there are many theories. Has the perforation occurred, then sealed back again? And from this perforation to sealing, some cells have seeped out. And there's another concept of exfoliation, where basically the cells of the tumor, as the tumor is obviously a T4 tumor beyond the confines of the organ, basically shed and exfoliate into the peritoneal cavity and then start acting. So nodal spread and distant metastasis is extremely unlikely. Again, PMP, we're basically talking about low-grade appendiceal mucinous neoplasm or high-grade. We rarely talk about adenocarcinoma when talking about PMP. So again, invasion of the basal membrane is less likely, and then hence lymph node metastasis or systemic metastasis is unlikely. Going back to the concept of, is it a systemic metastasis versus a dissemination of a local issue? So basically, it spreads by the redistribution phenomenon. It has a predictable natural history. As the disease progresses and as the mucin deposit becomes more and more, patients start complaining of increasing abdominal distension, colicky abdominal pains, and then they progress into difficulty breathing, and they frequently die because of recurrent multi-level bowel obstruction. As related to the best evidence we have now, the best treatment modality is considered the cytoreductive surgery in HIPIC. Basically, what it consists of, it's a big surgery. Consists of basically peritonectomy, bilateral parietal, and then greater and lesser omentectomy, appendectomy, possibly a right hemicolectomy, depending on the pathology. Hysterectomy and bilateral subpingual oophorectomy, again, depending on the pathology and if there's disease in the ovaries. And we'll be talking about that prophylaxis business. Diaphragmatic and pelvic peritonectomy, possibly a rectosigmoid resection. If you remember from the diagram I viewed earlier, that one of the areas where peritoneal fluid stagnates and a common area of nodularity would be the rectosigmoid area. All right, and then again, completeness of cytoreduction score, CC0 or CC1 is desirable because this condition is potentially treatable. Major tumor debulking, it's the concept of palliation because patients are fairly symptomatic, and with these severe pressure symptoms, they're expected to survive for quite a long time. We're talking about months to years. So maximal tumor debulking will be in an effort to palliate these symptoms. So this is actually a picture of one of my patients. I put this image on purpose just to show one thing. So this patient was admitted a few months ago. She was admitted as a case of pseudomyxoma, and she was planned for surgery. But then, unfortunately, we got hit by this coronavirus, and we had logistic issues with the operating rooms and with the anesthesia. So she got delayed quite a bit, and she was getting severely symptomatic, having trouble to breathe, having trouble to move, and she wasn't able to feed. We had to put her on parenteral nutrition. So as we were waiting just for an operation room to clear up, we put in a drain under CT guidance in an attempt to relieve this pressure. Eventually, what came out of the drain over the next 3 or 4 days was only about 20 to 50 cc's of serous fluid, and she got zero comfort after this. So again, I'll show you the CT scan. You can see this is the same patient's CT scan. You can see some omental kicking here and there, but it's very tempting to put a drain inside her abdomen, thinking that she will get some comfort out and relief from the pressure. But actually nothing came out. And this is the reason. This is when we finally got a chance to operate on the patient. As you can see, there's nothing to drain. It's all a bunch of mucin and tumors. So again, it's tempting to drain, but That's the concept of jelly belly. That's why they're called a jelly belly. The abdomen is full of thick, viscous, jelly-like mucus that's practically not drainable. And after the resection, we went ahead and did HIPIC, and the patient is doing that. All right, so down to some research. So the 5 and 10-year survival after cytoreductive surgery and HIPIC for pseudomyxoma peritoneale is 87.4 and 70.3% respectively. The 5 and 10-year survival after maximal tumor debulking is 39 and 8.1. You can see the vast difference. Prior surgical intervention and peritoneal disruption has major effects on outcome. Again, the tumor cell entrapment theory makes life very difficult and worsens the outcome. Adjuvant chemotherapy may be considered for high-grade disease or maximal tumor debulking. Again, it all depends on the tumor biology, whether or not the patient will benefit from this. Okay, now to appendiceal neoplasm, which is more or less a separate entity than pseudomyxoma, unless we're talking about the Lamin and Ham. So basically, 1% of GI malignancies, we've got a variety of tumors, epithelial versus non-epithelial, and epithelial are further subcategorized into benign or malignant. Benign including tubular adenomas, tubular villus adenomas with dysplasias that are high or low grade. Malignant, again, we're talking about Lamin and Hammond, which cause the PMP, and mucinous adenocarcinoma, mucinous signet ring cell adenocarcinoma, and then we've got this intestinal type, which is non-mucinous. Lamin was previously known as the mucocele of the appendix, which is the traditional teaching. If you see on CT scan or on operation, an appendix with a lot of mucin in it, basically a mucocele of the appendix, you should handle with care to prevent the possible disastrous outcome of pseudomyxoma. And then we've got the non-epithelial, which are the carcinoid and the mesenchymal cysts and sarcomas. For non-perforated low-grade appendiceal mucinous neoplasms, usually appendectomies is adequate. You don't need to do any more if there's no perforation and you don't see any cellularity or you don't see any nodularity in the pelvis. For Hammond and appendiceal adenocarcinoma, whether mucinous or not, usually a right hemicolectomy is indicated. Now, the risk of pseudomyxoma peritoneale in appendiceal neoplasms, whether the Lamin, Hammond, or adenocarcinoma grouped together, is from negligible to 52%. A group from San Diego did a study based on the risk of developing PMP after a variety of appendectomies, and they found that there's a risk of 1.8% if you performed an appendectomy and you found no extracellular mucin or epithelial cells. There was a 1.8% risk of developing PMP. This risk rose to 6.5 if there was mucin but no cells, and up to 26.5% if there was mucin and cells during the index operation. So appendiceal adenocarcinoma accounts for about 0.12 per million per year. Usually presents as acute appendicitis. Some centers advocate preemptive cytoreductive surgery and HIPIC as the index procedure if the appendix was obviously perforated. Lymph node status, signet ring cells, adenocarcinoid, those are the things that are associated with worse prognosis. Again, this is an adenocarcinoma, it's not a Lamin or Hammond, so you get the concept of potential for lymphatic spread. You get the signet ring cells, which obviously confer worse prognosis. And actually, 50% have synchronous or develop metachronous colorectal neoplasms. So usually a colonoscopy is indicated when diagnosed with appendiceal adenocarcinoma. So a study done by Peritoneal Malignancy Institute of Basingstoke found that 37% of people harbor peritoneal disease beyond the confines of a standard right hemicolectomy, people with appendiceal adenocarcinoma. So again, this gives rise to a discussion of whether or not every perforated appendiceal carcinoma should undergo preemptive or prophylactic cytoreductive surgery. So these are just a quick clinical practice guidelines. We're just going to be talking about this area. So you've got an adenocarcinoma, a mucinous one. If it was a low-grade, appendectomy should be enough. Adenocarcinoma, frank adenocarcinoma with the potential for lymph node metastasis and systemic metastasis, a right colectomy is indicated. And again, if you see peritoneal involvement, upfront cytoreductive surgery and HIPEC should be done based on this research if it was available at the center. Against predicting survival after cytoreductive surgery and HIPEC, ideally a PCI score of 7, of less than 7. If you remember the diagram we just viewed, based on the 9 quadrants and the 4 areas of the bowel, achieving complete cytoreduction is a must. Otherwise, CC0 or CC1, anything above that does not contribute to survival, and the pre-op CEA of less than 6. So you get an overall survival of 55.5, a disease-free survival of 36.1%. All right, now to colorectal peritoneal metastasis. Again, this is a separate entity. You got 70% synchronous, where basically at the index operation, the surgeon finds a colonic tumor with peritoneal disease, and 10 to 20% happen afterwards, where you find the peritoneal disease occurring months to years after the removal of the colon mass. So the risk factor for this are T4 stage, poor differentiation of the pathology, obstructional presentation, mucinous pathology, and sickness ring cell. So this study done by the North Center Cancer Treatment Group found that patients with colorectal peritoneal mets had a worse overall survival when treated with systemic chemotherapy as compared to non-peritoneal metastatic disease, with an overall survival, a median of 12.7 months. And the Dutch Cairo-2 study, where patients were given Capox plus Avastin or cetuximab, had a median overall survival of 15 months and the median progression-free survival of 6 months. So basically, this is the graph that tells us the purple line is the patients with peritoneal metastasis. The red one is with the liver mets, and the blue one is patients with lung mets. And we can obviously see that the median survival is obviously worse for patients with peritoneal mets. This is another study trying to predict the occurrence of peritoneal mets in patients with colon cancer. So basically, it's basically a questionnaire based on patient and tumor characteristics, and it devises a model predicting the chances of developing peritoneal mets, metastatic peritoneal mets, based on 1, 2, and 3 years post-operatively. So colorectal peritoneal mets after cytoreductive and surgery and HIPEC, 5-year survival was up to 40 to 60%. Multiple trials in France and the Netherlands have shown superiority of cytoreductive surgery and HIPEC over systemic chemotherapy alone, with 5-year survival rates up to 50% and the median survival of 62.7, as opposed to a year or 15 months on systemic chemotherapy. So, and then consideration of systemic therapy after cytoreductive surgery and HIPEC, this has to be discussed in a multidisciplinary team, and then taking into account patient characteristics, tumor biology, and aggressiveness. The role of neoadjuvant systemic therapy, so giving chemotherapy before going in for the cytoreductive surgery and HIPEC, has been debated, and some conflicting outcomes have been seen. Some have advocated neoadjuvant therapy, and some associated it with worse outcomes. And proactive cytoreductive surgery and HIPEC, again, the concept of basing the validation model of the chances of developing peritoneal carcinomatosis, metachronous peritoneal carcinomatosis, and discussing the concept of performing cytoreductive surgery and HIPEC on patients who are high risk to develop but have not developed the peritoneal metastasis yet. Again, this is up for debate, although most of the evidence as of yet suggests against it. But again, we have a long way to go. This is just a quick table just showing us the differences in survival percentage between systemic chemotherapy alone or versus cytoreductive surgery and HIPEC. As we can see, the 2-year survival, the difference is major, and the 5-year as well, in favor of cytoreductive surgery and HIPEC. But again, these studies have to be reviewed individually and then have to be I mean, taken with the limitations, and it's not something that we can take a conclusion out of. It's something that we need to just assess and build on for the future. All right, so this is just an evolution of cytoreductive surgery in HIPEC for colorectal peritoneal mets. It was basically discussing the complication rate and the median survival, where we have a 3-year median survival of 54%. All right, so this is just a quick diagram by Dr. Brenda Moran and Dr. Thomas Cecil from PMI Basingstoke, where they just wanted to set some guidelines for patients with colorectal peritoneal mets. So if a patient was diagnosed with colorectal peritoneal mets, if it was a synchronous mets, basically discovered on the index operation, if it was a preoperative diagnosis where it was diagnosed on a CT scan, a PET scan, or whatever, they need to be referred to a peritoneal malignancy institute. If it was an intraoperative diagnosis, again, we have to emphasize on no resection of limited disease, again, for the tumor entrapment theory. Limited resection or stoma for impending obstruction, just simple biopsies, explore disease extent and document them, and refer again. If it was a metachronous based on imaging, referral to a center. Again, here, that's another diagram for colorectal peritoneal mets. If they were non-resectable based on diagnostic laparoscopy or laparotomy or imaging, patients just go for palliative chemotherapy. Potentially resectable, maybe to start with chemotherapy and restage to convert it from marginally or potentially resectable to resectable, and that needs further research. So staging laparoscopy is one of the modalities that we can use to stage, because CT scans and MRIs and PET scans are notoriously inaccurate for the smaller nodules, and laparoscopy may aid us in further improving our accuracy in diagnosis. For resectable lesions, if it was a synchronous peritoneal mets in the index surgery and the center has the capability to perform cytoreductive surgery in HIPEC, it should be done up front. If the primary was resected, systemic chemotherapy and restaging. The reason for systemic chemotherapy and restaging is to deal with this tumor cell entrapment and basically try to treat the systemic spread of the disease that may have gotten into lymphatics that otherwise wouldn't have been there in the index surgery, and then to go for cytoreductive surgery in HIPEC after restaging. Metachronous mets, if the primary was resected, if the mets happened less than a year, again, patients should opt for systemic chemotherapy and restaging. If it happened more than a year, then upfront surgery would be ideal. So basically, this is a picture of the specimen of one of our patients who presented as an emergency. Basically, they had a splenic flexure mass, and we went ahead and did upfront subtotal colectomy with removal of the mass, peritonectomy, and HIPEC, and the patient is actually doing very well. So this graph just demonstrates the differences in overall survival based on pathology. Now, I cannot emphasize more on the importance of tumor biology. It makes a huge difference. It should be part of every MDT discussion. I think starting with tumor biology is how we can individualize patient care. There's no point in treating a patient with colorectal peritoneal mets from a colon adenocarcinoma with signet ring cells, treating them like a patient with an appendiceal lamin who just happened to have peritoneal mets. It's not fair. So we can see here the overall survival difference between lamin, Hamin, and colorectal peritoneal mets. You can see the median survival is different. And again, the completeness of cytoreduction. If we had to choose whether to perform a complete cytoreduction or just to perform a HIPEC, surgery would always win. Again, it all relies on surgery. The chemotherapeutic, the intraperitoneal heated chemotherapy, just aids in clearing the microscopic disease. If you cannot clear the macroscopic visible disease, there's no point in putting in the medicine. So you can see the overall survival between the blue line, the CC1, and the CC2 and 3, which is basically leaving back behind microscopic cells. You can see the median survival it's different. Okay, now to ovarian cancer. So ovarian cancer, the problem is patients usually don't develop symptoms until they're advanced. They frequently present at advanced stages with peritoneal involvement. The previous management was based on debulking rather than peritonectomy. Now there's a huge difference in going in, accessing the abdomen, opening the peritoneal cavity, disrupting a few planes, and starting to debulk the tumor cells out of the abdominal cavity. It's going to leave some disease behind for sure. Peritonectomy-based resections usually take out the whole envelope based on the fact that mucinous cells and the low-grade ones especially don't go beyond the basement membrane. So if I'm able to remove the whole envelope and put in my heated chemo, that's where the cure happens. So debulking rather than peritonectomy usually yielded survivals of up to 35 months. Cytoreductive surgery and HIPEX usually yielded survival of up to 45.7 months. Again, this is based on a heterogeneous population of cancers that were both low grade and high grade. Further studies need to address the population of low grade tumors with low potential of invading basement membranes, low potential of lymphatic and systemic spread. All right, so this is just a graph showing the recurrence-free survival and the overall survival of patients who underwent surgery plus HIPEC or surgery alone. And we can obviously see the difference in the median survival in favor of surgery plus HIPEC. All right, now peritoneal mesothelioma. It's extremely rare disease. And again, it's a big heading that can be further subdivided. The incidence is about 0.5 to 3 per million. It's got multiple variants, as we discussed, multicystic, well-differentiated, papillary, and we've got the diffuse malignant. So, and then each type has a different aggressive biology. It has notoriously has a poor response to systemic therapy with a median survival of 12 to 27 months. And studies have shown that after complete cytoreductive surgery and HIPEC, survival rates have jumped up to 53 months. All right, so now we've done talking about the separate pathologies. Now we have to address the rationale of intraperitoneal delivery of chemotherapy. What has it changed? So again, isolated tumor mets, as I said before, rarely go beyond the basement membrane, depending on the tumor biology and pathology, of course, and usually do not become solid organ mets or dissemination. So intraperitoneal penetration chemotherapy is about 1 to 3 millimeters based on the research. So you got a delivery of a uniform high-dose chemotherapeutic right onto the affected site. So imagine if you were able to achieve a CC0 or a CC1 site reduction. I'm sure now we're familiar with this terminology. And you have a chemotherapeutic that you can deliver in a good enough dose that can penetrate 1 to 3 millimeters in depth. The concept is that this chemotherapeutic will be able to take care of the microscopic disease. So basically the concept is the elimination of microscopic disease after successful site reduction of all microscopic disease. And usually part of the cytoreductive procedure is adhesiolysis is an essential component of HIPEC. Again, this increases the surface contact of chemotherapy in areas that would otherwise be poorly perfused by systemic chemotherapeutics. We've got the peritoneal plasma barrier, which basically acts as a barrier that allows the larger molecular weight chemotherapy molecules to stay in contact for longer periods of time inside the peritoneal cavity before eventually being cleared. So again, you can have higher intraperitoneal dosage of chemotherapeutic with lower systemic side effects because of this peritoneal plasma barrier. And then you've got hyperthermia. So heat per se has a direct anti-tumor effect. A temperature of about 40 to 43 degrees directly induces cytotoxicity in tumor cells that have impaired DNA repair. So the heat would act on the tumor cells like the normal cells of the body. But the thing is, normal body cells usually have the capacity to repair the DNA. Cancer cells do not. So this heat has an additive effect on killing the tumor cells, plus it augments the chemotherapeutic penetration. So this is just a quick drawing showing how the drug delivery in the intraperitoneal route usually is affected by the molecular weight, the size, charge, and ionization of the drug molecule, temperature, and concentration of the chemotherapeutic in the liquid being delivered into the abdomen. And so the peritoneum is an organ that consists of about five distinct layers. It's about 90 micrometers thick, and I mean, by comparison, it's devoid of this extensive vasculature. So systemic chemotherapy would not work as well for peritoneal nodules as direct application of the chemotherapeutic. So this is just a quick graph showing us the area under the curve for chemotherapeutic, namely mitomycin C, when given in plasma versus intraperitoneal. You can see at 90 minutes that the delivery of intraperitoneal mitomycin has shown a more sustained dose rather than the systemic chemotherapy, systemic mitomycin, which usually takes some time to get a steady state and then drops. So this is a meta-analysis of multiple studies done for gastric cancer. Again, gastric cancer is one of those cancers that may be approached with cytoreductive surgery and HIPEC. Here, the assessment of intravenous plus intraperitoneal chemotherapy versus intravenous chemotherapy alone, those are those study arms are after complete cytoreduction. So we can see distant metastasis, peritoneal recurrence, and positive rate-free cancer cell detection in body fluids after the surgery. And we can see that the results are all in favor of intravenous plus intraperitoneal chemotherapy. Again, this is the same meta-analysis assessing the 1, 3, and 5-year survival in patients with intravenous plus intraperitoneal versus intravenous chemotherapy alone in gastric cancer. And we can see that these results also favor intravenous plus intraperitoneal chemotherapy. All right, now to our local experience. It's not a very extensive experience, but again, based on a lot of logistic factors, a lot of factors related to the coronavirus, we had to slow it down. But I think that we're starting to gain momentum. So our first procedure was in February of 2020, and as of today, we have completed 10 procedures. Our PCI ranged from 8 to 30, and completeness of cytoreduction ranged from 0, most of our patients being 0 or 1, but we had, unfortunately, 2 patients where we could not achieve cytoreduction, and we just did maximal tumor bulking. Our 30-day mortality and in-hospital mortality was 0, and in terms of post-operative complication, we had 3 patients with Clavian Dindo complication score of 3 or above. Unfortunately, we had to take 1 patient back because of wound dehiscence, and the other 2 were basically an inspissated collection that needed to be drained by interventional radiology. And our follow-up, before talking about our follow-up, basically all our patients are discussed in a multidisciplinary meeting, including radiologists, ourselves, medical oncologists, and I think because our hospital does not have a dedicated medical oncology unit, it's a good thing. We were able to tailor our patient follow-up based on 2 centers. Now this, to me, I think gives more weight to our evidence. At any point in time, the medical oncologist can give me a phone call and tell me, you know what, I think I did a CT to one of your patients, and I think he has a recurrence, and so on. So this dual center follow-up, I think we're lucky to have. We have probably the best medical oncologists around. They teach us a lot of stuff. And I think working together will again present a lot of benefits and advantages for our patients. Again, we have an independent radiologist who's making a great effort and trying to determine the preoperative PCI based on CT and MRI. Hopefully, in the soon future, we're going to publish our own paper based on the best radiological modality to diagnose PCI. And so our patients get followed up in our hospital, in Amiri Hospital, and with medical oncology at their center, at their center. And then we collaborate all our data. They get imaging either in Amiri Hospital or over there. And whether the imaging was done there, I usually view it on a CD at our hospital. And we frequently discuss our patients' outcomes. We still have a long way to go. We haven't completed a year of follow-up for any of those patients. But again, I'm doing basically daily phone calls with the medical oncology, just going over this patient care, patient follow-up, and how can we improve. So I think we're doing okay. So this is just a quick intraoperative picture. I'll be going through some of our techniques for cytoreductive surgery and HIPEC. So this is one of the patients where we with a pseudomyxoma peritoneal, where we prefer to go by extraperitoneal dissection, trying to achieve all the margins we can before going into the abdomen. And this is where we completed almost extraperitoneal dissection, including stripping of the diaphragms and going all the way to the back. It made life a lot easier. Then we go in and access the abdomen. As you can see, this is the omentum with a lot of nodularity, delivering the tumor out, applying the chemotherapeutic. We go using the open Colosseum technique. We find it easier to reproduce, easier to do, less troubleshooting, everything you can see yourself. Again, manipulating the bowels. A lot of our patients that come to us have usually been operated before. You get a lot of fibrosis. You try to take out as much of the fibrosis as you can, but I find that the open technique with manipulation of the bowel helps a bit. All right, that's one of our specimens. So, in summary, cytoreductive surgery and HIPEC has shown promising results in a lot of tumors. Again, emphasis on tumor biology, peritoneal carcinomatosis index, completeness of cytoreduction, and response to chemotherapy, because these all make a difference. Careful patient selection. Again, you've got a maximum PCI of 39. A lot of studies have reported that you shouldn't go above a PCI of 20 or 26 as a maximum. I still think we have a lot more work to do to further stratify those PCIs in relation to the tumor biology. MDT approach for every patient. Again, MDT approach and individualization of care for each and every patient, because you don't get the same patient twice. Complete cytoreduction versus HIPEC, we already talked about it. Is the complete cytoreduction more than the HIPEC? Does it confer more? Does it have more weight on the overall survival and prognosis? Probably yes. So doing a complete cytoreduction and adding the HIPEC will just give us additive effect based on the best available evidence yet. Although we have quite a few studies that have negated that and said that HIPEC does not really add much. Again, these studies need to be officially published. We need to have a look at them, critique them, and then discuss this further. Yeah, again, I mean, our aim is to primarily provide safe treatment based on the best available evidence for this patient population. Our second aim is to provide good quality evidence from which sound conclusions can be made, and we're hoping to contribute that to the international community. Thank you. Any questions?
Thank you, Dr. Ali, for this presentation. We have a few questions in the Q&A panel. But before that, anyone who would like to participate verbally, any points to discuss or ask questions, please raise a thumb where we can see, and then I can unmute your mic. Until we have, I think we have Elnet raised hand. Okay, let me just. Okay. Okay, so Elnet, I don't have the full name. Your mic is unmute. You're allowed to talk if you have something to participate.
I'm not sure, Shaima. I can hear you.
Can you hear me now?
Yes, we can hear you, yes.
Yeah. Okay. My name is Dr. Abdulsalam Al-Najjar. I'm a consultant medical oncology at the GI unit in Kuwait Cancer Center. This was interesting talk, Ali, about the approach for HIBIC. But we want to go further, from medical oncology and as well.
Sorry,
can you hear me or not?
I think he has an issue with the mic. Dr. Ali, you can't hear us?
Okay.
I think you have an issue with the voice because I can see Dr. Najjar clearly.
So Shaima, you can hear me, huh?
I can hear you. I think Dr. Ali has an issue. Can you check the voice sound, Dr. Ali? Maybe it's mute.
Yes, I can hear you now.
Okay. Sorry, Dr. Najjar.
Okay, you can hear me, Ali, now?
Yes, I can hear you. Yes.
Can I continue? Okay. So the question is about, you remember, we talked about it. So actually I have two questions. So the first one, you remember we chatted about the uni cancer trial, if you can remember that trial. And this trial has an issue about the HIBIC and cytoreductive surgery, and what they found is that there is no survival using the HIBIC procedure. So I had best of ASCO last year, and there is a guy who do HIBIC surgery, and he had a criticism about this trial. And just I want to ask you if you agree with him, because what he said is that first of all, there was actually benefit when they went retrospectively for this trial, which with a patient with a PCI of more than 15. The other thing, they said that the trial actually in in Europe, they used the oxaliplatin versus the mitomycin, which they use in USA. And the other thing is that the timing of the infusion, which is 30 minutes in Europe, compared to 90 minutes in USA. And also the temperature, I think they use a lower temperature, which I think in the States they use 42. So this is the first question about your interpretation to this trial, and if you agree with what we say. The second thing, we had a chat around a few weeks ago about should we do HIBIC for patient who has like a solitary, let's say, liver met or solitary lung met, and what are the solid tumor that will be candidate for that? Like the colon or the gastric, should we include the pancreas? And if you have any data about that issue. So thank you very much.
Yes, so the first question actually is a very good question. It's probably a bit too advanced, but we'll talk about it. Talking about the latest publications, and again, as I said, some literature wasn't published. I mean, it's not officially published. With regard to oxaliplatin for 30 minutes, I wouldn't call this an obsolete regimen, but it will soon become obsolete. More and more centers are adopting the mitomycin regimen, the 90-minute mitomycin regimen. Talking about the unicancer, the phase 3 trial, and maybe with more relevance, the PRODIGE 7, which will soon, everyone's waiting for that to become an official publication, where oxaliplatin for 30 minutes added no survival benefit. But when, again, assessing the subgroup, there was a slight survival benefit in the moderate PCI, basically 10 to 15. There was a moderate benefit of cytoreductive surgery and HIPEC. Again, we can spend all day, all week critiquing the design of these studies. We're going to need to go back to the fact about biology of each and every tumor. I mean, how invasive was it? Was it a lamin, a hamen, a mucinous adeno? Were there any signet ring cells? What was the percentage of those signet ring cells? And again, we need to have sound knowledge of the pharmacokinetics and pharmacodynamics of each and every medication. It might sound a bit primitive, but we're using the same ampule of the intravenous type of chemotherapeutic and putting it into the machine and using it as an intraperitoneal chemotherapeutic. To me, that's a bit primitive and needs a lot of work. The delivery mechanisms for intraperitoneal chemotherapy need to match the dynamics of the procedure. And lastly, I would think that again, this to quote Dr. Marcelo Draco, if you're resecting the peritoneum, which we still need to label as a systemic mets versus a dissemination of a local problem. So if I remove the peritoneum with complete site reduction and I place the chemotherapeutic, it wouldn't be fair to assess this outcome per se in terms of survival. Let me put it in other words that might make it a bit easier. Imagine I have a patient with Crohn's disease that gets referred to me with an ileostenotic, with a fibrostenotic stricture of the terminal ileum, and they happen to take out that stricture and do an anastomosis, and they end up dying a year later. Would someone come to me and say, you know what, we might as well not do the surgery because they'll eventually die? It's not fair. Cytoreductive surgery and HIPEC is aimed to treat that extensively disseminated local problem inside the peritoneal cavity. Patients dying of lung liver mets 1, 2, 3, 10 years later wouldn't be a fair assessment. So again, quoting Dr. Marcelo Draco, the peritoneal free recurrence or the local free recurrence rate would be a more fair assessment of the outcome of this procedure. Again, cancer is a systemic disease. Peritoneal mets that do not invade the basement membrane, do not develop lymph node mets in the retroperitoneum, do not develop systemic mets in the lung or liver, I wouldn't call them metastasis. That's the first question. The second question is regarding cytoreductive surgery for other solid or hollow organ cancers. The concept is there. I mean, for urachal, for pancreatic, for gastric, the concept is there. It still needs a lot of refinement, again, because of the lack of the number of cases. I'm sure it will take us years and years before we reach a consensus for each
Ali, sorry, Ali, can I interrupt you? My question was not like this. My question was for a patient with peritoneal met and solitary liver lesion. So that with this scenario, either colon or gastric or pancreas, are they eligible for HIPEC? So this was the question.
Yes.
Okay.
Yeah.
So meaning you have a gastric colon cancer, and then you have a solitary liver met with peritoneal or 2 liver lesion that might be resectable with the peritoneal disease. Can we go with HIPEC plus resection of the 2 liver lesion, or this considered as a contraindication? And if it is considered, and if it is yes and no, will it be allowed in colon and gastric, but not allowed in other cancer type like ovary? So this is my question.
Yeah. So having solitary mets to the liver or to the lung is as of yet it's not a contraindication to cytoreductive surgery and HIPEC. It depends on the patient characteristics. But again, the algorithm might differ a little bit. Would they opt to go for neoadjuvant chemotherapy? And this, again, is discussed in an MDT. For example, my preference is to check for the in vivo response. So if the patient can wait, he does not have a lot of disease. I mean, in the peritoneum, the disease burden based on pre-op imaging and assessment is not too high, but has a lesion in his liver. I would like to check the in vivo response of the chemotherapeutic. If his liver responds, that's a very good thing. I would proceed for the cytotoxic surgery and hyper. Again, if they progress after the neoadjuvant chemotherapeutic, it would be counterproductive to undergo such an extensive procedure with patients that did not show any response to chemotherapeutic. So it's not a contraindication. It would just change the management view. All right. Dr. Shayma, let me just go through the written Q&As. Okay, so one question here: would mucolytics through the drain help in any way to ease the abdominal pressure? Again, mucolytics, I'm not sure if they were studied at any point in time, but this viscous fluid, in terms of physics, talking about the caliber of the drain, the length of the drain, and the viscosity of that fluid, I would doubt that any mucin would go through that drain, despite how much mucolytics you would give. Again, a question: what is Lamin and Hamen? Lamin is a low-grade appendiceal mucinous neoplasm. Hamen is a high-grade appendiceal mucinous neoplasm. They're considered malignant, but they do not invade the basement membrane. So very low likelihood of lymph node metastasis. Another question: is splenectomy essential? With left subdiaphragmatic peritonectomy, it's not always essential. If the spleen is involved, we take it out. If it's not, we can always strip the peritoneum from the left diaphragm without taking out the spleen. For the liver, we usually do glycine capsulectomy, removing the glycine capsule with the nodules. Another question: how do you avoid complications of overheating in HIPIC, and how would make sure that HIPIC was successfully done intraoperative? I'll show you the machine. So basically, you've got a HIPIC machine. You've got a lot of brands, probably 5 or 6 companies that produce it. This machine takes care of business, where you usually heat. This is the chemotherapeutic here. It goes through the pump, the centrifugal pump, and then gets heated here by the machine and goes in. And then there, I'm sure it's not very clear. Here you have the temperatures inside. So you attach thermometers to all your tubings to make sure that the temperature is maintained throughout the procedure for the whole 90 minutes. And then you can always harass whoever is mixing the chemotherapy, like how it happened last week with Dr. Shayma. I always ask her to dip her hand inside to make sure that the fluid is really warm. All right, is sign MRI available in our hospital? Now, I'm not sure about that. The radiologist who's actually conducting this is assessing the different MRI protocols. We still haven't decided on what to go with yet. We still have a very long way to go, and we'll keep you posted. So what role is cytotoxic surgery and HIPIC suitable for metastatic carcinoma, pancreas, biliary tract, stomach? So again, Dr. Rashid, good evening. Again, it depends on the patient's response. For the more aggressive tumors, namely stomach, pancreas, we would have to see the patient's response to the chemotherapeutic, the in vivo response. If they progress on chemotherapy, it would not be worth their while undergoing such an extensive procedure. Gastric cancer, cytotoxic surgery for gastric cancer, I've already shown the meta-analysis. It confers a better prognosis, better survival. For pancreas, it's the same concept. The problem is with the high risk of complications, pancreatic leaks after HIPEC. So again, they would have to have a good response to the chemotherapeutic before embarking on such a big procedure. Okay, in case of 2 steps procedure, that peritonectomy and stoma done, is it fine to go again for HIPEC? If so, what about the stoma limb below the skin? Yeah, so this is a very technical, it's a very good question. Again, when you're doing the site reduction, you have to always keep in mind that I need to minimize as much as I can the compartments where the chemotherapeutic would not reach. Meaning, I would rather do my anastomosis after I perform the HIPEC. I would rather take down all the stomas, keep them inside the abdomen, keep them bathing, do as much as adhesiolisis as you can in an attempt to make the peritoneal cavity or whatever remains of the peritoneal cavity after resection a single compartment where you can mix the chemotherapeutic around. One question, would you please comment on the rate of post-op complications of HIPEC, like abdominal pain, abscess, collection? All right, so HIPEC as a procedure is a procedure with a relatively high complication rate. The mortality rate has been cited by some centers as up to 5%. Morbidity rate can reach up to 20 to 25%. Morbidity, basically, the general morbidities after any major surgery, including the wound infections, the intra-abdominal collections, and those. Some complications have been reported that are unique to HIPEC. From my experience, there have been a higher than usual rate of intra-abdominal collections, especially when you do major peritonectomies. Recovery takes long. It's usually well known between surgeons that perform this kind of procedure that usually the patient does not feel after like 3 to 6 months post-op. So again, we have to keep this in mind when doing such a large procedure. If it takes 3 to 6 months for this patient to recover completely, again, we have to assess the tumor biology. And then something that is often overlooked, and we're trying to grasp that with a proper study, is the psychological impact of the procedure. Patients usually, as they recover, or first a few days after the surgery, it's not very clear, it's not very evident, but usually a week or 2 after the surgery, you start noticing that psychologically the patient is not as sound as they were pre-op. So this needs a lot of attention. And again, there was one study, I did not cite it here, where a transcranial Doppler was done during the surgery, and it showed a severe reduction in the cerebral blood flow during the hyperthermic phase. Again, this needs to be looked at. Right, in peritoneal MRI will depend on diffusion-weighted imaging and contrast-enhanced images. Sure. Thank you, Dr. Ahmed Samir. Dr. Ahmed Samir is the radiologist taking care of business with preoperative PCI, and I'm glad to say that he's been quite accurate up until today. So we're hoping to do a lot of business together. All right, Dr. Shema, do you have any questions from the audience, or are we done?
Is there any further questions? I can see Dr. Asma Rashid is raising her thumb. So, Dr. Ali, do you have time to take this question?
Yes, I'm sure that we always have the time for Dr. Asma.
Asma, your mic is unmute.
Hi, good evening, everybody. Can you hear me?
We can hear you clearly.
Okay, fantastic. So first of all, thank you so much for this amazing talk. My disclosure is I'm not a colorectal surgeon, but what I'd like to say is I really commend you on the work that you have done and the service that you have established. And as everybody like starting a service wouldn't be an easy, and it's important to have, standardization of protocol and services, setting KPI and so forth. Especially looking at clinical outcomes when it comes to procedures like that. So I just have one question. What are the challenges so far that you've been having? Because doing 10 patients during the COVID COVID-19 pandemic is actually a success. At least this is the way I see it. So what I would ask is that what are the challenges so far that you have establishing the services, and how can you overcome them? Thank you.
All right, thank you, Dr. Asma. So in terms of challenges, I'm sure those challenges have been experienced by everyone else in the whole world. Lack of beds, lack of post-operative ICU beds, lack of anesthetic doctors, lack of OR time. So basically, it was a logistic nightmare. But then again, I think we're blessed with having a very cooperative anesthesia and ICU staff. They were happy to accommodate when they had the means. But again, we fell behind because of this issue. So again, it's mostly logistic. We're trying to overcome it. In terms of ICU bed coverage, we had to take some patients back to the general ward, put them in a high monitored bed in the ward. Some nights we had to spend the whole night next to them just to make sure everything is good. So it was a challenge, but again, we aim to overcome these and become standard. In terms of KPIs and standardizing protocols, I think we're still a long way to go because there is no algorithm that has gained consensus throughout the whole world. So we still have different chemotherapeutics being used at different concentrations, at different temperatures. And so I think this still needs a lot of time. I think in this period, we have adopted one protocol, and based on our best reading of the literature, on our best understanding of the literature of tumor biology, pharmacokinetics and dynamics of the chemotherapeutics, which is a very important thing. And we've adopted this, and we're trying to expand on it, and possibly maybe even contribute to the international guidelines one day.
Thank you, Dr. Asma. I think we're done with the questions. So anything you would like to add, Dr. Ali, before we end this session?
I would like to thank everyone for attending this lecture. I hope to be giving some proper updates very soon. In terms of sharing our experience, I know it's not much. Sharing on 10 patients on less than a year's experience wouldn't count as evidence. I'm hoping in the near future we can possibly be sharing proper evidence and contributing to guiding the management of such a rare disease. Thank you very much, everyone.
Thank you, everyone, for joining, and thank you, Dr. Ali, so much for your presentation.